But I'd like to welcome our next session on global cancer health disparities, and our chairs, Dr. Damiano Rendelli and Dr. John Scheel. So thank you so much.
Hello, my name is John Scheel, and I'll be introducing Dr. Benjamin Anderson. He's an international expert in breast cancer detection, diagnosis, and treatment. He's a professor of surgery and global health at the University of Washington, and he's the founder of the Breast Health Global Initiative. He's going to be talking today about geographic disparities in low and middle income countries.
And I have the pleasure to introduce Binay, Dr. Shah, as a speaker, the second speaker of the session. Dr. Shah, you all know him very well for his amazing initiative of this conference and the Binaytara Foundation. But he's a board-certified hematology oncologist. He trained actually at UIC and is now at Peace Health United General Hospital here in close to Seattle at Cedar Woolley. And he's been interested in research in health outcome in cancer and in cancer globally and locally for many years. He's published he has many publications, and his work has grown over the years around the world, mostly in Nepal and India, by implementing actually what has been learned here in areas where there is no access to care. He's working on I think we will hear from him, his work in Nepal in building capacity and allowing millions of patients to access cancer care. So it's very exciting to have a global perspective. I think it's not going to be very different from what we've heard until now. The issues are very similar locally and globally when access is limited and cancer disparity is an issue. So with no further delay, we'll have the first speaker, Dr. Anderson. Thank you.
So while we're pulling up the slides, I'd like to thank Binay and the organizers for inviting me to participate today. And so what I will be talking about is disparities in low and middle income countries. But I hope to branch beyond the discussion of what are the disparities into and how do we address this? Because if all we do is note the obstacles and problems, then that becomes a limitation. The Breast Health Global Initiative was jointly sponsored in the beginning by the Fred Hutchinson Cancer Research Center and Susan G. Komen for the Cure. I do not have any personal disclosures. I do want to mention that we ran a global summit last October here in Seattle, and these are the sponsors that helped provide support through unrestricted educational grants. I'd like to begin by talking about some of the global cancer trends as they relate both in the United States and in the rest of the world. Actually, between 1/3 and 1/2 of cancers can be prevented through avoidance of known risk factors. Tobacco control would be the most obvious example of this. However, for the remaining 50%, a substantial portion of cause-specific mortality could be averted not through prevention, but through early detection followed by treatment. The data from high-income countries indicates that prevention and early detection programs are cost-effective. But as was discussed earlier, we have limitations in terms of our data from the low and middle-income environments. I'm going to be using breast cancer as a model because it is the most common cancer among women around the world and the most likely reason that a woman will die of cancer. But the patterns that we see, however, are applicable to other solid tumors. Here is the incidence of breast cancer around the world. The darker colors means higher incidence. And so look at the high-income countries and see dark color. When you look at mortality, you'll see the reverse of that graph is true. So mortality rates are high where incidence rates are low. This relates in part to screening behavior and screening activities, because if we don't go find the cancers, we don't know that they're there, but of course they will present at advanced stages. Actually, when you look at the United States, and this is male and female cancers, you can see that breast cancer is head and shoulders above all of the other cancers in terms of incidence. That in and of itself is quite interesting. What is this about female gender that predisposes to this cancer versus others? But you can also see that the demographics have been changing since the early 1980s, and this is largely, but not exclusively, attributed to screening behaviors. What you can see is that because we started screening in the early 1980s, because of the HIP trials showing improvement in breast cancer mortality, as published in New York in the late 70s, we started looking for the disease. Now, what was really quite interesting about this is that you can see as we started to screen, there were certain types of cancer that were found more often, in particular, the node-negative cancers and ductal carcinoma in situ. It was commonly assumed that when screening would begin, that as we saw more early-stage cancers, we would see fewer late-stage cancers. That actually did not occur in that one-to-one relationship that one might have thought. And I think what we're seeing is that actually there's more heterogeneity in this population. There's some cancers that are very amenable to early-stage detection, and that's where mammography fits in the most. There are others that have aggressive biology from the very beginning, and that's where treatment plays this essential role. Now, if you then follow and say, well, what happened after we screened? It was about 8 years after we started the screening that we started to see population-level mortality improvements in the United States. So you have to realize when you start early detection efforts that there is a delay before one is going to actually see the outcome. But this also gives us hope. It says, look, we're able to do something here, and it is measurable at the population level, not just the individual level. But of course, as we were talking about earlier, as Dr. Nguyen addressed, we have disparities in the United States. So here we have white versus black statistics in incidence and mortality. And there is a gap between these two. What I would say, there is a certain hope here in that while mortality rates are higher among African Americans than they are in Caucasians, the patterns towards improvement are occurring. And so, as Cliff Hudis had said, they're coming together. We need to do more work in this area, but something is working right. The American Cancer Society did a very nice analysis of these trends. What is it that's different between Caucasian and African American women? And they deduced that about 1/3 of the excess risk of mortality among African Americans is related to insurance. So it's actually access and insurance that makes a really huge difference. It is the irony that we seem to be talking about whether we should be insuring people in the United States when if there was a single most powerful risk factor for poor outcome with cancer, it's lack of insurance, and that is a global phenomenon. So now we've been talking a lot about treatment. I want to shift into the prevention and early detection discussion, but recognizing the two are absolutely linked. So primary prevention is like tobacco control. It's eliminating or minimizing exposure to risk factors that would then induce cancer through carcinogenesis, tobacco control. Early detection is where we find cancers at earlier stage of disease. This is often in high-income countries equated with screening, and that's actually a misconception. Screening is a subset of early detection. So finding cancers at earlier stage includes finding cancers when they're smaller rather than larger, whereas screening means looking in asymptomatic populations using some type of intervention, which in general we think of mammographic screening in this environment. But screening and early detection are not one and the same. We actually have to think of one as a subset of the other, and then ask the question, what do we apply in which settings? So ideally, we would prevent cancers. That it's inarguable. If we could not have the cancer in the first place, that would be best. But if primary prevention is not a realistic option, or if it really only would address a relatively small subset of the cancers, that's when we need this complete set. You have to find the cancers at points at which they are optimally treatable. You have to prove that it's cancer within a reasonable period of time, and then you need to provide the treatment. Looking at treatment versus early detection is like arguing about whether you want your left hand or your right hand more. You really want both. Because if we only have late-stage disease, we will continue to do poorly with cancer with all of the drug availability. If we only do early detection and don't treat them, why would there would be no improvement in outcome? So it's a system that we have to be thinking through as we address this. Now, there are three ways in which we can find breast cancers. One is because the woman finds a lump herself or some change in the breast and brings it to the attention of the provider. The second is through some type of healthcare provider evaluation, which includes a history and physical, or there's imaging. There is nothing else. We don't have a genetic test at this time that finds cancer. Maybe that's coming in the future, but that does not exist. We, of course, struggle with the whole area of guidelines. How do we screen? What does our evidence tell us? And how do we think about this in the context of disparities and limited resources? So the American Cancer Society most recently came out with revised guidelines for mammographic screening. And they suggest that we begin at age 45, which is halfway between what U.S. Preventative Services Task Force had said when they said 50, versus the NCCN, which age 40, and we could talk about the evidence, but the bottom line is that's not an unreasonable place to start with mammographic screening. They suggested that we actually screen less often in women over 55, and that's because every time we do the mammograms, we have a certain false positive rate that's going to result. But actually, it's hard to show a difference in postmenopausal women between screening every year and every 2 years in terms of overall mortality outcome. They said that there actually is a stopping point. So if someone is expected to live less than 10 years, it really does not make a lot of sense to do mammographic screening because they are so unlikely to be dying of breast cancer. And then they made this statement that clinical breast exam is not recommended for breast cancer screening. And this is problematic that they've said this. What ACS was thinking about was a very narrow interpretation of our data. What do we know about clinical breast exam in terms of mortality? And they were not thinking about the real world limitations that is the case. First of all, when they made that assertion about clinical breast exam, they were making the assumption that all women were getting screening mammograms within the ages that they had recommended. And that is actually not true in much of the US and certainly in most of the world. Actually, mammographic screening is unaffordable in most of the world when you look at the overall balance. They do not reflect the critical role of clinical examination in diagnostic workup and treatment. So now some of the physician groups are saying, okay, well, we're not going to do physical exam anymore because that's what ACS told us to do. That actually was not what they were saying. So we also do not have randomized trials about the value of a stethoscope. But no one said, let's throw the stethoscope out and forget about that. So we don't have the same for history and physical. It's part of routine care. And if we stop doing clinical breast exam, that guarantees that our providers will be poor at it when they're actually posed with the problem. Furthermore, if you look at the ACS recommendations, they provide no guidance for women under age 45. They don't recommend self-exam. We could talk about that and how that data, I think, from the Hutch was somewhat misinterpreted. They don't recommend clinical exams. So what are we saying to women if we follow this? Under 45, you're on your own. We hope you figure it out. And we forget that actually healthcare delivery is more than just what the evidence shows us. But in fact, there is a lot to say about mammographic screening, seeing it as an entire system. The Canadian trials were one of the sets of trials that tends to send people off into outer space as they argue about mammographic screening. So the main issue with Canada, they had done these randomized trials, and what happened was that Tony Miller, who is one of the leaders of this group, every 5 years they republish the data, which shows between those women randomized for screening mammograms versus not, no difference in overall survival. And so those that favor mammographic screening then criticize the Canadians, well, either you messed up your trial, or you cheated, or you just don't know how to do a mammogram. And I think that's really an unfair piece. It's also not really looking at the evidence. Because when you look at the evidence between the mammographically screened arm and the control arm, what you can see is that the median tumor size in the control arm was approximately 2 centimeters. Well, actually, 2 centimeters is not bad at all. This is very different from India, where the median tumor size is 4 to 6 centimeters in size. And so actually, I think the most interesting question from the Canadian trial is not, were you messing up your mammograms? The question is, what were you doing in the control group that allowed you to find the tumors at that 2 centimeter mark? Because that's the information that would be most useful to the rest of the world. Now, WHO has been thinking quite a bit about this. And what you have to realize is that when you screen, if you look at the left side of your diagram, the screening group, if you screen 1,000 women, you may find 10 cancers in that group. But at least 100 of them are going to require some type of diagnostic workup when you're looking at this asymptomatic population. If, on the other hand, you wait and you're finding women who have palpable abnormalities, it's a much smaller group, much more practical group to look at. Now, this is not a screening versus early diagnosis. The point here is you have to be able to do early diagnosis before screening is even a relevant question. And so this idea of clinical evaluation, it's not going to go away anytime soon. Actually, when we look at the early mammographic screening trials, clinical exam was finding about 60% of the cancers. Today in the US, perhaps 60% of the cancers that we treat are screen detected. But that means 40% of the cancers are clinically detected, either because they weren't in the screening age group or because they presented with an interval cancer. So we have to be doing clinical evaluation to find these cancers. Some are not even seen on mammograms. This whole breast density discussion, this is part of the reason that clinical exam, all of the clinicians in the room have seen cancers that had a negative mammogram. That it's not an uncommon event, and sort of pretending they don't exist is not a very good systems way of thinking about it. In fact, clinical exam is necessary. So this idea of do we do it, do we not do it, I would argue is really not thinking in a holistic or systematic way. Actually, we do have prospective randomized data about clinical exam from India. There currently are 2 sets of trials that have been ongoing where women are randomized to either clinical exam or observation without clinical exam. And so this is one of those 2 trials and from India, and we have one of our leaders from these trials here. What is really interesting about this trial, and which I don't think has received adequate acknowledgement, is that when you look at those women who were randomized to to CBE, you can see that they were in fact finding more cancers at earlier stage. They did not see a difference in the later stage cancers. And so far, they've not seen a mortality benefit. But this is clear evidence that clinical exam does downstage. And downstaging, I think we can argue, is a necessary prerequisite. I'm not sure we're going to ever see a mortality benefit in India because you have to provide comprehensive treatment. And we've been hearing about all of the limitations. That isn't happening in India. So it seems that I'm not sure that mortality is the right endpoint. And when we're thinking about necessary steps for improving outcome. The Breast Health Global Initiative worked with colleagues in Indonesia because they were asking questions about mammographic screening versus clinical exam. So Cardana, who is a radiologist in Jakarta, had led this trial in which they were in this study in which they trained nurse midwives and volunteers to do clinical breast exam, and they did mammograms and clinical exam in parallel and followed up on these women to see how did things go. 1,179 women had both mammograms and clinical breast exam. About a quarter had some finding that required a workup. So you see, from a systems standpoint, we tend to think of, well, there's the mammogram and then there's the treatment, and we forget that there's this big middle piece that is absolutely essential to improving outcome. So you have to plan for the benign biopsies as a component of what it is that we did. Now, they found 14 cancers among those more than 1,000 women, which is about what you'd expect in a screening trial. Of the 14, 13 could be appreciated on clinical breast exam. So the point here is not that mammograms don't work. The point here is that when you have a previously unscreened population, your initial round, you're going to be finding the prevalent cancers that are already clinically detectable. Mammographic screening only works when you repeat it, whether it be every year or every 2 years. So a single mammogram is not of benefit. If you're going to set up a mammographic screening, you have to be prepared for the whole set, not just this brief part. Now, what we also found was of the 14 patients who had cancer, 8 were never treated. When we asked why was that, 2 refused and 6 were lost to follow-up. So that ended the study. Because you see, if you can't treat them, then the early detection doesn't help. But this also points out that when we're talking about our systems, we've been talking about randomized trials. We think in this very purified way about randomized trials. This is quite different from implementation science today, where we're talking about pragmatic trials, what really happens in the environment. What really happens in the environment is there are a lot of women that don't get treated, and it also points out you have to have longitudinal care as a component of your work. So if you can't follow the patients over time, you cannot effectively manage cancer, nor could you manage hypertension, diabetes, or any of the other chronic diseases that we're now holding under this umbrella of NCDs. So how do we work to improve on systems? This is where the Breast Health Global Initiative got started, and it was for the development of resource-stratified guidelines. So I'm going to talk about this briefly, and then I want to make a response to something that Cliff Huddes said a little earlier today. So as we started doing this work, we said it's very obvious that the high-income country guidelines don't work in most of the world because they assume you have all of the tools, which isn't true. You usually have some tools, but not all of the tools. So we came up with this approach where we said, let's take all of the standard tools and we'll put them in a priority list based upon the biology of the disease. Basic level resources would be those that you cannot do without. So today, breast surgery is required for cure. We do not have a way of reliably making breast cancers go away that do not involve removal of the breast primary. I think one could argue that tamoxifen fits in this area. It is so powerful, it's a medication, it's practical, that really belongs at the top of the list. Limited level resources would be next level up. Most of the drug therapies that we talk about are in this category, that we have prospective randomized data that says people will live longer by virtue of these treatments. Third tier, there are some treatments that are highly desirable but may not improve survival. Doing breast conservation therapy, a lumpectomy with radiation as opposed to mastectomy. Women don't live longer because we conserve the breast, but it may make it more acceptable, and we may get more participation, thinking broadly. And then there's some resources we should not be focusing on. And our highest level imaging, breast MRI, gosh, we use it every week in our clinic. But if you ask how many lives does MRI save, the answer is 0, and it has to be 0 because it doesn't matter what kind of picture we get. We already know that there's no improvement in outcome by virtue of taking out the whole breast versus part of the breast. So we did these resource stratification tables for healthcare systems, early detection, diagnosis, and treatment by stage. The thesis here is if we could just do the things that we already know work, we'd be making improvements in outcome. Now, the point that Cliff had made was that there are many in countries that are resistant to this idea of resource stratification. And this is the same obstacle that we hit in the mid-2000s, where people said, you're certifying substandard care. That is not what's happening here. What we're doing is we're prioritizing how you would build a system. So because there's some things that come before others. Mammographic screening does not come before treatment, for example. And so it's how do you build in a logical way? I have to start with the foundation before I think about the penthouse. And that's not certification of substandard care. It's a different concept. So in early detection, doing a history and physical, that's basic level. You have to be able to do that. And actually, there are many countries where doing a clinical exam or clinical evaluation is not even in the medical school curriculum. So there's an obvious, you have to at least know what an early cancer looks like in order to detect it. Diagnostic imaging, ultrasound comes before mammography because ultrasound is incredibly useful for palpable masses. Mammographic screening comes down the road. Again, it's just putting it in an order. It's not saying, good news, you can stop here. NCCN has now embraced resource stratification, and I will show you the work that they've done. And that is they've taken their standard guideline, they use their expert panels then to say, let's follow this out, how do the resources play out? So here is that third level, enhanced level. You can see that in grayed out, you can still see it on the guideline, but it's saying these are lower priority than the black items that are indicated. In the core level, they substituted core for limited, which was our terminology. They're saying, there are alternatives. You may not have CT, but you can do pretty well with chest x-ray, abdominal ultrasound, and plain films. This is how we used to do it. So at least informing people how that a ministry, how you could set this up with existing resources is relevant. Then we think about the basic level. If you take away everything, it gives you this skeleton. And the point of basic level resources is not you could stop here. It's that if you can't do these things, then you should probably be fast forwarding to palliative care. You shouldn't be trying curative therapy because you already can predict it's not going to work. So it's a different way of thinking about it than certifying substandard care. But what NCCN then did, which I think is really powerful, they, working together with the American Cancer Society, the Clinton Foundation, and IBM, they pulled together a group of sub-Saharan African countries, and those representatives looked at the NCCN guidelines, and they said, here's where we think we are. So they identified their own path for as certification of standard care for sub-Saharan Africa. And what was really interesting hearing them present this at the UICC meeting was they kept talking about our NCCN guidelines. It wasn't a bunch of Americans standing up there going, here's what you need in your country. And you see, I think this is an important step that we need to be thinking through as we do this. NCCN has now done resource stratification for 3/4 of the cancers around the globe. So I am not arguing that these are perfect. What I'm saying is it's a tool. And if we want to say, well, if you want to do colon and breast and lung, what can I do with these resources? We now have a lever that's evidence-based about how you might address this. Now, Tanzania is a country that we have been involved in for doing situation analysis, and it gives you a point about early detection, the sort of systems things we tend not to think about, especially when we come from here. So Tanzania has been addressing breast cancer. They're starting because they recognize that more people are living longer, as Clef Hudis was pointing out, and so it's a looming problem. And so they invited us to come with, together with Komen, to do a situation analysis. And so there's a report that's available online. This is just one minor point from that. And in this report, so in many of these countries, you have this pyramidal system where you've got the primary care facility, which is where the patient first touches the system, and then you have the national level centers of expertise, where that's where most of the treatment lives. What we found was that the first place that a needle biopsy could be done is level 4. So in theory, then, the woman would say, I've got a lump in the breast. She goes to the primary care facility who sends her to the secondary level, and they say, oh yeah, we can't do this. 3rd level, 4th level, now I get a diagnosis. Well, think of how many women are not going to follow through with that. So what's the standard discussion about Africa? Oh, well, they just don't have so many breast cancers, but they're really bad, the ones that they've got. Well, you can see the system is selecting for that, not intentionally, but until this is pointed out, it's not going to get better. So what's happening now, the ministry is saying, we need to create a way where the women can go directly from primary to 3rd level, and we need to bring the needles to the 3rd level. This type of analysis, systems analysis, is where you identify the gaps that otherwise would not be obvious. And that's led us to say we're starting to see this as a spectrum of the patient pathway. There's the patient side, where she first identifies an issue or problem or has a screening mammogram. There's this diagnostic phase where you prove that it's cancer, and then it's followed by treatment. When you break down the diagnosis, you can see that there's this clinical evaluation, imaging, tissue sampling, and ultimately pathology. And this middle piece is the part that is usually overlooked. But if you can't make a diagnosis within 60 days, failure is predictable. And so thinking about diagnosis, I would argue, is more important than how do we screen. That's the high-level, high-income country question rather than ours. So Peru is an example where one of our colleagues, that there's some projects that have been going on together with PATH, and one of our trainees, Anya Romanoff, when she was a Fogarty Fellow, did this very nice study. It was simple, but it makes some really valuable points. So they took all of the women that were seen in their regional cancer center in the northern part of Peru, every new cancer diagnosis, and they interviewed them and surveyed them and said, what was it that led to this point of this being diagnosed? And they were comparing delay, how long did it take to get here and get a diagnosis, and also stage at diagnosis. And what you can see at the bottom is that the delays on the patient side were very significant, 211 days. But even more alarming, the delay within the system from when she first touched the system to when a diagnosis was made, 241 days. And we know that those cancers on average will be progressing during that time. When you found out how were the cancers identified, the patient herself found it 93% of the time. So the idea that self-exam doesn't work, which was a very narrow question about teaching self-exam as opposed to letting someone discover the lump in the shower, actually most of the world, the women are finding the cancers. And that's why we need the awareness education. When you have a painless lump and it's not going away, this is why you need a diagnostic workup. That level of education is essential. The mean delay was 407 days. But here was the interesting finding. If the woman said, yes, I had a clinical breast exam sometime in the past. Somebody did a breast exam. Compared to the women that did not have that experience, those that had a prior clinical exam were more likely to show up sooner and to have earlier stage disease. So the point of this is that clinical breast exam, it's more than a detection tool. It's more than it's not a replacement for mammography. It's also an educational tool. And so, if you do a clinical exam and then she feels a lump later, I think it's more understandable.